U.S. national statistics. And the reason why I chose to share this slide with you is not to show how many cardiac arrests we have on an annual basis in the United States, but rather to demonstrate to you the graph on the right. As you can see, since the implementation of therapeutic hypothermia on patient after cardiac arrest, specifically on the outpatient basis, we've seen an incredible improvement in survival to discharge from the hospital. We've gone from close to about 3% back in the early 2000 to now almost 12% over the last couple of years. So this is a remarkable therapy, in my opinion, to improve outcome, and I hopefully can share some more data with you in a second. The definition is quite simple. It simply is to reduce the core body temperature of the patient down to 32 to 34 degrees centigrade to reduce end organ and or neurologic injury. You can see I've highlighted 32 in red because recently there's been some intriguing data that even getting closer to 32 degrees centigrade may translate to even better outcome. The mechanism is not well understood, but it's hypothesized to be multifactorial. The more fascinating piece of it, however, in my opinion, is the ability to reduce the oxygen consumption by the end organs, reduce the oxygen consumption by the end organs by close to 30 to 35%. And that has significant implications on the patients that may have a failing heart while they're trying to recover from a cardiac arrest, as I will share with you a little bit later. So let's just go briefly over and talk about who we need to cool and how we cool these patients before we talk about some of the cardiovascular issues. Clearly, the ventricular fibrillation population has had plenty of data. 2 randomized controlled trials published in New England Journal of Medicine in 2002, which were landmark trials back then. The Hackett trial you may have heard of up here, and then a smaller Bernard trial on the bottom of the screen were 2 randomized controlled trials where they utilized patients and divided them into the usual care, where they either received standard ICU care or they would receive also therapeutic hypothermia, about 50% in each of the arms. The patients were cooled to a target temperature of 33 degrees centigrade with external cooling, ice packs, whatever they had available at that time to get the patient down, and they kept them there for about 12 to 24 hours. And then they rewarmed the patients back up to core of 37 degrees centigrade. And the very impressive findings of this is that you can see is those that had favorable neurologic outcome in the normothermic group was 39%. 39% in the normal thermic group had favorable neurologic outcome. This is contrasted to those that received therapeutic hypothermia, out-of-hospital cardiac arrest, therapeutic hypothermia, 55% survival with good neurologic recovery. So clearly a significant improvement in outcome in this patient population. And the key feature to this, in my opinion, is that you only need to treat 6 people. 6 people, ladies and gentlemen, to get one favorable neurologic outcome. And we've discussed this in the past. There's not a lot of studies out there where you have that significant impact with such minimal therapy. This is the Bernard data, relatively similar. It was a smaller study, and you can see 49% favorable neurologic outcome in the hypothermic group as compared to 26 in the normothermic group. And they used both studies used the CPC scoring system of 1 and 2 as being good outcome. So with that, the American Heart Association has gone from a 2A indication to cool patients with out-of-hospital cardiac arrest to now a class 1 indication. So in the United States, if we don't cool these patients, you're probably not providing the best care for these patients. And these are patients with a shockable rhythm, being unresponsive, and obviously you don't cool those patients that are fully recovered and awake. A little bit more tricky patient population to discuss are those with non-shockable rhythms. There's been 3 large registry reports on this over the last several years. As I've shown to you here, the hypothermic group versus control did not demonstrate any significant difference in the two patient populations. And we do know the limitations and shortcomings of registries in the sense that the data can be very mixed and the reports are not always reliable. We looked at the same data and the same patients from our own data set and our own patient population. We've cooled over 300 patients in our institution. And when we looked at our data and compared it to our historic controlled, we found almost a 29% survival with good neurologic outcome in the non-shockable patient population, as compared to around 10.4%. We were lucky enough to be able to publish that in Resuscitation last year, and hopefully that will have some convincing to you that you should also cool the non-shockable patient populations, those that don't come in with fibrillation or ventricular tachycardia as the original rhythm. The American Heart Association has made this a Class 2B indication. There's no randomized controlled trials to look at this, so you'll never see a Class 1 indication for this. Perhaps a 2A in the future if we find more convincing data. But essentially, in my opinion, if the patients come in with a non-shockable rhythm, there's a reversible cause, and we always use the example of pulmonary embolism or something to that degree. They're unresponsive. It may be a good consideration to cool this patient population as well. As you know, 2B really means that you're not doing any harm by applying this therapy. The benefit is not as certain. How to cool? Well, it's multiple different ways of doing it. However, it is a 3-step process. As you can see, the induction phase is simply doing a very rapid cooling to target temperature of 33. I've again put 32 on parentheses here because there is some emerging data that getting the patients to 32 may have more benefit. You maintain them thereafter for about 24 hours, if not longer, and there's now speculation that cooling according to the ischemic time and the ischemic burden may be more beneficial than simply doing a 24-hour on everybody. In other words, if the patients are seizing, when you start rewarming them, it may be smart to recool them back to target temperature. And then, of course, the rewarming phase, which represents a slow, controlled temperature of rewarming. And the reason why we do it very controlled is obviously to avoid reflex hyperthermia or rebound hyperthermia. The application of therapeutic hypothermia, how do you start cooling them? I look at it as 3 different approaches. You can have a iced saline approach, which we always use. We give 1 to 2 bags of that, and I'm going to share that data with you. You can do surface ice packs cooling until you get a destination device in the patient, such as an intravascular cooling, and I'll share with you what we use. We like to use something that has a biofeedback mechanism so that once the patient hits the target temperature, the machine stops cooling the patient and maintains them. That makes it very elegant as you're going through the ICU care with those patients. Like I mentioned, you can use the iced saline, as you see here. You have the intravascular cooling devices. You have ice packs that you can do on the patient. The iced saline is nice because it really has a good chance of at least getting the patients close to target temperature. And remember, patients that have a cardiac arrest will often have a right ventricular dysfunction as well as a left ventricular dysfunction, and may require some preload. In other words, they are somewhat preload dependent. And so the volume also assists with that piece. Do that 1 to 2 bags, bolus, and of course then you have the endovascular cooling device in place. Not sure how well this projects, but these are the cooling catheters that we use. There's multiple different sizes. This is the Quattro catheter, which has 4 balloons that cool down the patient with ports for drug delivery. It sits in the inferior vena cava, and it's removed within 72 hours of rewarming the patient. So it's, again, a very elegant system. The catheter is placed by the ICU team, the cath team, the emergency team, and that's really a very smooth process. Comparing surface versus intravascular, I just want to share this one study with you where there is a fairly large failure rate of cooling patients with surface cooling. About a third of patients do not reach target temperature because of multiple factors, but probably the most important being the BMI of these patients is so large that the patients are not effectively cooled. Time to target temperature, I alluded to that earlier. You want to get them rapidly cooled. This is somewhat of a debated topic, but I do think it's going to pan out to be true that you want to get them cooled very quickly. From this smaller study now published about 5 years ago, you can see that a multivariate analysis, time to target temperature was an important predictor of neurologic outcome. I mentioned earlier, historically we've been cooling patients to 33 degrees centigrade. However, a recent study or report on basically a pilot study that was reported at the American Heart Association this past year found that patients that were cooled to 32 degrees centigrade as compared to 34 degrees centigrade, so 2 degree difference, actually fared much better than those at a little bit of a warmer temperature. So I think what we're going to start seeing more and more of are people being cooled a little bit colder to 32 degrees centigrade. Some of the things to be aware of when you're doing pharmacotherapy on these hypothermic patients are that all of these drugs that we use unison in our ICU, and the reason why we do that on all our hypothermia patients is prophylactically, and I know a lot of infectious disease people kind of look at me like I have two heads when I say that, but prophylactic use of antibiotics for 3 days to prevent aspiration pneumonias and other infections have, in our experience, been very, very beneficial for our patients and may be a useful tool for you when you're doing other applications of therapeutic hypothermia. As you know, some of the stroke data was relatively promising with the exception of the infectious process that you see with a lot of the patients. Needless to say, all of these drugs that we use on patients do have a change in their serum concentration during cooling. In other words, the serum concentration will likely be increased in this patient population. So just be aware of that when you're prognosticating, especially if you have drugs that may cause sedation, etc. Bleeding has been a talk that people have been aware of, and I'm bringing it up because a lot of our patients will also undergo a PCI or angiogram, and that obviously poses a risk of bleeding. Despite this theoretical risk that exists, we have not been able to demonstrate a lot of bleeding episodes. In fact, the randomized control, such as the HACA trial, was unable to demonstrate that there was a significant bleeding risk in these patients, even in the presence of antiplatelets and heparin-like agents. Infection is more of a problem that you may see in the therapeutic hypothermia group. It's something that we've been challenged with, and that's why we've talked a little bit about this antibiotic therapy. There's two speculated reasons why there's a decrease in the immune response. It's the chemotactic activity that you see and also the decrease in the phagocytic activity, which translates into a delayed immune response. You can see in the patients that don't even receive therapeutic hypothermia, prior to the therapeutic hypothermia era, there was still a significant number of people that would come in and then develop an infection during the ICU stay, 46%. Most common infection was a lung infection. Now taking that and applying hypothermia on top of that, there's been an even higher increase in the infection rate to now closer to 67%. So this poses a problem, especially in patients that are coming in with an MI and you want to reduce the infarct size. Should we do it? Is there a benefit? Stroke patients, do we want to cool these patients with the risk of developing an infection? We looked at our data because we started immediately out of the gate when we started our program. We instituted antibiotics on our patients. And we looked at about 115 patients and found that prophylactic unison on these patients translated to a significant reduction in infection rate. Zero bloodstream infections, BSIs. Pneumonias were reduced to close to 16%. So you remember me saying some of the other studies with hypothermia, 67%. and we're reporting 18%. There is no control group here, so I cannot tell you what the other side would be if we didn't treat them with antibiotics. But needless to say, there's clearly a potential benefit for these patients. So in summary, there is a risk of infection in the patients that receive therapeutic hypothermia. Unison may be an agent that you should consider using. So let's talk a little bit about the cardiovascular system. Acute coronary syndrome patients. Patients that come in after a cardiac arrest and are found to have ST segment elevations on an EKG should undergo therapeutic hypothermia. It does not affect the door-to-balloon time. It improves mortality. Simply the patient hits the ER door, they get their antiplatelet agents, they get ice packs and cold saline, they go to the cath lab, get the vessel open, and then they go into the ICU where they continue with the cooling process. I will caution you that the only antiplatelet agent that's been studied somewhat is clopidogrel, and they actually found that only about 5 of the 25 patients that they looked at, they were able to get the platelet inhibition to an acceptable level of less than 0.5. So I'm not sure what that translates into clinically, but certainly from a platelet inhibition point of view, it may not be the best agent, and we are learning that as we go along anyway. And just for the record, I do not have any affiliations with any of these antiplatelet groups. Cardiac catheterization timing. Well, we know patients that come in with a cardiac arrest, it is likely driven by an ischemic event, cardiac, either an acute coronary syndrome or ongoing ischemia. A study reported by Spalding many years now ago in New England Journal of Medicine found 48% of the patients to have fresh thrombus on angiogram that did not correlate with EKG. So you cannot always use the EKG as a marker if these patients should go immediately to the cath lab. In fact, over 70% of the patients ended up having significant coronary artery disease. So the message to me, or the way I interpret this, is that most patients that come in after a cardiac arrest should and deserve to have an angiogram immediately. You'll probably get some resistance from some of the cardiologists with that, and probably, I'm not one of them, but some of my colleagues perhaps. So you may negotiate that all STEMI patients go to cath lab, and then you treat the other groups pharmacologically until you find a neurologic improvement or if they have ongoing ischemia. Prinzmetal angina is an interesting but small population in this whole picture. As you know, the mechanism for Prinzmetal angina is simply vasospasm, and the coronaries from baseline, even if you don't have Prinzmetal angina, are very responsive to cold temperature, and they constrict more than any other of the vessels. Now, if you have vasospasm disease on top of that, that can be quite profound. So in patients with this condition, it's recommended by me only, so you have to take whatever data you want to, not to cool these patients. In fact, if you see patients develop ST segment elevations on their EKG during cooling, it likely means that they have vasospastic angina. And as you know, the tricky part of that is that they may fibrillate because of the ischemia. So again, it may be one of those rare times when you don't cool the patients. The ejection fraction, after cardiac arrest, the ejection fraction will go down substantially. Pre-arrest to 58%, 5 hours of 25%. This is seen in both this study as well, but if you apply therapeutic hypothermia to that, you may attenuate some of this depression in the ejection fraction, and holds true, as you can see here, by the fact that mild therapeutic hypothermia improves myocardial contractility, and it actually increases the cardiac output by the mere fact that you're reducing oxygen consumption, as I alluded to early on. Remember I said about 25 to 35% reduction in oxygen consumption will translate to a significant improvement in the cardiac output, again, which can help that failing heart during the recovery for that patient. This has been speculated by many people, including Ullman, published as a position paper in JACC last year, where they reported that there is an increase in the contractility, decrease in oxygen consumption, decrease in inflammation, and an increase in the cardiac index, you don't have to deliver as much oxygen to those end organs to maintain viability, even if the ejection fraction is substantially reduced. Other conditions that occur with hypothermia, as you know, is the bradycardia. We see this all the time. You get conduction delay. Everything sort of becomes more prolonged. This does not translate into more shockable rhythms. You don't start seeing VT and VF in these patients as a result of this. If you see VT, VF in someone that's being cooled, it's either because they have recurrent ischemia or there's some electrolyte imbalance. It's not the cooling in itself. Defibrillation threshold is unchanged in this patient population as well. In fact, it may even be somewhat improved. SVR, the systemic vascular resistance, is increased, probably related to the viscosity, and also vasoconstriction, which leads to less vasopressor need. And we know from a lot of the shock trials that vasopressors translates to worse outcomes. So if you can reduce the amount of norepi, dobute, and epi that you use, you may do better for the patient. This was reported in critical care medicine last year, where you see that those that were cooled in blue actually required less of the traditional vasoactive agents, norepi, dobute, and epinephrine, as compared to their control group. STEMI patients, you may have come across some of these trials. There was a ICIT trial now reported a few years ago where they looked at about 228 patients. They wanted to see infarct size on 30 days if they cooled the patients when they came in through the ER. These are not cardiac arrest patients. They simply had a STEMI. The interesting thing is that they were not able to demonstrate a benefit in this patient population. So it was a negative study. But they went back and did a post-hoc analysis on the same group and found that those that were cool or cold prior to opening up that vessel, prior to going through that plaque or that thrombus, those patients had a 43% reduction in infarct size as reported by a SPECT imaging modality. So that led David Erling to re-evaluate this. He did a study that just was completed in Europe with endovascular cooling, and patients were cooled prior to taking them to the cath lab. And this study is going to be presented this year in the European Society of Cardiology. So this is my conclusion. It's a class 1 indication for shockable rhythms out of hospital cardiac arrest. I do want you to think about the non-shockable rhythms as potentially also patients that you want to cool. There are complications related to mild therapeutic hypothermia, infection probably being the most challenging one that there may be solutions to with the prophylactic antibiotics. And there are now other uses for hypothermia that we're starting to learn about, especially in the shock patients where you reduce the oxygen demand by the end organs. With that, I will let the next speaker come up. Thank you for your attention.